I'll be speaking first on Amblyopia, Mimickers, and Masquerades. So what's a mimicker and what's a masquerader? So I think I will clarify this first before moving on to the topic first. So an ophthalmic mimicker is usually a lesser known disease which closely resembles a familiar ophthalmic disease and confuses the clinician. For example, a cataract which can masquerade as a squint, or a retinal pathology which can masquerade as a squint. Whereas a masquerader is usually a dangerous disease which can disguise as an innocuous condition. Just like that, for example, retinoblastoma masquerading as a squint. So that is, I'd like to say, this is what is a mimicker and a masquerader. So we're going to look at some amblyopia mimickers. So let's look at this case scenario of a 19-year-old healthy girl. She was accidentally noticed to have blurry vision during a driving license test 6 months back. She had consulted elsewhere and was extensively evaluated and was told that she was probably having a refractive error with amblyopia and even the possibility of malingering because her visual acuity was 6/24 N6, not improving further with glasses or pinhole. So when we saw her, she had a normal ocular alignment. She had good binocular vision as Würzburg daughters showed fusion, but stereopsis was just about borderline, 200 arc seconds. Pupils were good, there was no RAPD, color vision was full in both eyes. And this was a fundus. It essentially looked normal to us initially. And we actually had a cursive glance to the OCT. It didn't really ring a bell then. We did a visual fields. She had bilateral central scotoma. It was repeated, again bilateral central scotoma, a pattern VP, full field DRG, EOG, all way within normal limits. So we thought we'll have a closer look at her OCT and also at her multicolor picture. You could see there were this small yellowish white retinal flecks, a suspicion, not even flecks, some deposits at the macula. And the fundus autofluorescence was very dramatic. She had this, hyper autofluorescence on FAF. And that's when we thought, let's look at the macula closely. And we found that she had some amount of foveal atrophy with ISOS junction disruption, which was and this raised the strong suspicion of, are we really dealing with an amblyopia or is there a structural problem? And then we thought this could be an early macular dystrophy. So that's when we did an MFERG, and you can see here there is reduced foveal peak in the right eye and the foveal peak in the left eye is absent. So then we thought of doing a genetic analysis, and to a surprise we got an ABCA4 mutation, came out as positive, and this ABCA4 is, it is indicated in Stargardt's disease and ABCA4 retinopathy. So probably we were dealing with a case of ABCA4 retinopathy or an early Stargardt's. So there goes the importance of doing a detailed evaluation. So next was this 15-year-old 10th standard student, again was referred for squint surgery. He was diagnosed to have strabismic amblyopia. He had a right exotropia, resistant to patching and glasses. When I saw him first, I thought he was relatively short-statured for his age. He was cushion-eyed, baby-faced. For a 15-year-old, he really looked underage. So then I looked into his fundus. This was his fundus, bilateral optic disc pallor. We did an OCT. There was definitely retinal nerve fiber layer thinning in both eyes, right more than left. And something was not right. I did the fields. This is the field I got, bitemporal hemianopia. So definitely he must be having something, and we imaged him, and this is what we got. He had a large pituitary macroadenoma, which was compressing his chiasm as well as the right optic nerve, and that was the reason for his right, both bilateral optic atrophy, right more than left, and him going into an exotropia. So he was referred to the neurosurgeon. He underwent a surgical excision, but I think he continues to have poor vision in the right eye. The third case was again referred as anisometropic amblyopia, a 7-year-old healthy boy, best corrected visual acuity not improving beyond 612, 618, no history of consanguinity, no similar illness in the family, color vision was poor. This is his fundus. Optos picture initially looked good. I couldn't find any abnormality. But there was something in the history. His father was saying he's stumbling at objects at night. That was the catchy thing. So we did an ERG, and you can see here the photopic responses are all good. But look at the scotopic or the dark adapted responses. Even you have a negative B wave here. So can you see this is the A wave, and where you are supposed to have the B wave, it is a negative B wave. So that brought us to the suspicion, are we dealing with a case of night blindness? And that's when we did the genetic analysis, and he came out positive for the TRPM, that is the transretinal protein mutation positive. So that is again very points to the diagnosis of congenital stationary night blindness. This is another case of an 8-year-old boy, again had poor vision, right eye fairly okay, 612 N6, left eye CF2 meters, N36, compound hypermetropic astigmatism, diagnosed as anisometropic amblyopia. Right eye was okay, left eye had some patches of subretinal fibrosis, and you can see these pigmentary changes. He definitely had a pathology in the left eye. And on a closer look, you could see this schitic areas, which was beautifully delineated in the OCT, and this turned out to be a case of juvenile X-linked retinoschisis with a bicycle spoke wheel maculopathy. Another case referred to us as refractory ametropic amblyopia, 11-year-old boy, difficulty in vision, squeezing eyes. And again, he had compound myopic astigmatism, no history of consanguinity. Fundus essentially looked normal to us. But the red flags in the history were poor vision, poor color vision. He was squeezing his eyes even in the room light in my OPD. Fine nystagmus, and sister having similar complaints. Again, an ERG was done, and you can see here the scotopic responses are very good, but look at the photopic responses. The light responses are totally absent. So this, again, we did a genetic analysis, and the CNGA3 gene came out as positive. So this was a case of achromatopsia. Again, this girl was referred as amblyopia, poor vision, myopia. Fundus looked normal, except that I couldn't get the foveal reflex. So she had poor vision, nystagmus, photophobia, no foveal contour on OCT. So this was highly suspicious of foveal hyperplasia, and we are evaluating her. So there are a lot of literature search, evidence for mimickers and masquerades of amblyopia. We had a similar case of a child referred for squint surgery, eventually turned out to have a brain CNS glioma. It was masquerading as an esotropia. So what I want to say is that to rule out before you think of amblyopia, get a detailed history, establish an amblyogenic risk factor before you label as amblyopia, rule out an organic cause, and do ancillary investigations, image wherever necessary. Electrophysiology does help, and genetic test clinches it. All that does not see well is not always amblyopia. Thank you.